Thanks for joining us tonight. I'm Darla Clayton. I'm the East Coast Fundraising and Community Engagement Specialist for Angioma Alliance. Welcome to, I'm going to read the name of this webinar so I don't mess it up, Neurosurgical Management of Cavernous Angioma, including some additional information about vitamin D with Dr. Park. Before we get started, if we could just use the Q&A to submit questions rather than putting them into the chat box, that would be great. All right, I'm going to pass it over to you, Greg.
Great. Good evening, everyone. I am Greg Upwall. I am the Vice Chair of the DC area, or I think we're called the Greater DC Community Alliance. It's a lot of G's and D's and C's in our name. And that covers Virginia, Maryland, and DC, the Mid-Atlantic area. I have volunteered to moderate tonight, so I'll be reading the questions that you all submit to Dr. Park. And before we get started, I'll just mention my involvement with Angioma Alliance. I am a carrier of the disease. I have the familial condition. Mine was originally diagnosed 25 years ago. I had a brainstem cavernous hemangioma removed from my brainstem by surgery, and several other members of my family are affected. And so with that, I will read the distinguished bio of Dr. Park, and I want to read all of this because there's quite a bit here. So Dr. Park trained at the UCSD and the Barrow Neurological Institute under Robert Spetzler. In addition to his neurosurgery career, Dr. Park has a distinguished service career. From 2009 to 13, Dr. Park served as Lieutenant Commander and Staff Neurosurgeon at the Navy Medical Center in San Diego. He deployed to Kandahar, Afghanistan in support of ongoing Operation Enduring Freedom, where he was the sole neurosurgeon for the southern half of the combat theater and performed over 150 life-saving operations in 6 months. He was honorably discharged from active duty service and completed an endovascular neurosurgery fellowship at the Barrow Neurological Institute in Phoenix. Dr. Park then joined the neurosurgery faculty at the University of Utah, where he was the director and founder of the Endovascular Neurosurgery Fellowship and Associate Residency Program Director of Neurosurgery. And he was then recruited to the Department of Neurosurgery at UVA. Dr. Park is currently the Director of Cerebrovascular and Endovascular Neurosurgery and Associate Residency Program Director of Neurosurgery at UVA. He is an Indiana native, and he earned his doctorate in medicine from the Indiana University School of Medicine in 2002. He completed his general surgery internship and neurological surgery residency at the University of California, San Diego Medical Center. And with that, I would turn it over to Dr. Park.
Well, thank you very much, Darla and Greg. This is an absolute honor and a privilege to be speaking on this webinar. We will talk about cavernous malformations and some of the research that is being conducted on the role of vitamin D. And what has been happening throughout medicine is vitamin D is a it's been a very hot area of research in the medical field in general. It started getting noticed when people started looking at the inflammatory mechanisms that vitamin D plays in, as well as for bone development. And a lot of the early research was in orthopedics, but as we started to learn more and more about the multiple roles that vitamin D plays in the human body, people started looking in the critical care world and also in neurosurgery outside of spine in the cerebrovascular realm, where my subspecialty is. That's kind of where my interest in this started. So I have no disclosures. So just as a background information, vitamin D, it's a fat-soluble steroid. It's considered a secosteroid, and it's generally absorbed in the gut with other minerals and nutrients. It's involved in multiple processes in the human body, and we've discussed upon a couple of those. And inflammation for this audience is probably the most important one, as well as some of its roles within vascular genesis. There are a couple active forms of the vitamin, ergocalciferol and cholecalciferol, vitamin D2 and D3, that's found in the human body. Even though that we can take multivitamins and through our diet, it's mostly through sun exposure that we get the most amount of vitamin D. So it's always a good idea, especially now that summer is kind of waned, that you get out there and do something active out in the sunlight. However, we do know that there's a high prevalence of deficiency in the population, especially in the elderly population, where more than half of them will have a deficiency of it. And a lot of it, again, is secondary to exposure to the sun, as well as dietary deficiencies that many people can have. And like I said, with the research that's been going on, especially in the neurocritical care world, there's been multiple associations with negative outcomes, and both in terms of mortality within the hospital, pulmonary and respiratory diseases such as acute respiratory disease syndrome, and infections as well. There's been a lot of research looking at whether or not you can affect outcomes, at least in the hospital in the critical care setting with supplementation of vitamin D. And one of the distinct advantages of this form of treatment is that it is very inexpensive. It's very safe to administer, and it's something that, again, a lot of people do take supplementation of vitamin D. So has potential benefits in terms of function, as well as cost and wide availability to the general population. So just going back a little brief background into some of the work that I've done with vitamin D, we looked at multiple things. First, my research looked at cerebral aneurysms, which are a function of wear and tear on the blood vessel, as well as inflammatory process. So we looked and we were trying to determine if vitamin D deficiency had anything to do with patients who presented with cerebral aneurysms. And through an extensive review of the medical record, we were able to find that patients who had low levels of vitamin D were more likely to have cerebral aneurysms that were to go on to require treatment. And this is kind of an interesting finding. It's not a causal relationship. It's not that you have low vitamin D and then you're going to develop aneurysms, but we did find that of the patients who had the aneurysms that were more likely to require treatment, either because of how big they were, what their morphology, what they look like, if they had multiple high-risk features, for one reason or another, we did find that these patients tended to have deficiencies in vitamin D. And we continued on, as much as anyone who does research understands, sometimes you just either grab the little string on the sweater and you just keep pulling and more comes, or you follow the rabbit down the hole, just like Alice in Wonderland, and you end up opening new avenues of research. Based upon what other information was out there in the literature in terms of vitamin D and its role in the critical care setting, we actually looked in our neuro intensive care unit and determined, we tried to see if there was a role or an association between patients who had low levels of vitamin D and their outcomes in the hospital. And this, we were able to identify that patients who did have vitamin D deficiency were more likely to have worse outcomes in the hospital, as well as longer stays in the intensive care unit. This is a pretty interesting finding. It had never been identified in neurosurgical or neurological patients before. As you can see, with the emergency admissions, and these are patients that were admitted to the neuro-intensive care unit for non-elective reasons. Like if you have a cavernous surgery that you have planned, and you spend the night in intensive care unit, that's what we consider an elective admission. Emergency admissions they're coming through the emergency department or through the trauma bay, or there's something that happened that required a non-scheduled admission. And in those patients, there was a statistically significant difference in terms of mortality and, for all reasons, mortality for patients who did have vitamin D deficiency. And this held through multiple statistical analyses. And again, the part that's relevant for our discussion is that vitamin D deficiency did seem to have an association with outcomes in the hospital and in-hospital mortality. So this was pretty exciting for us because this had never been documented in the neurointensive care unit. And again, just like research, as that poster in grade school with Garfield, the little saying, the more I learn, the more I learn how much I have to learn. This started our research even further, looking at vitamin D deficiency. We followed this out again for 3 months after their discharge from the hospitals, and not only were they having worse outcomes while they were in the hospital, but when we saw how they did of those survivors who went on to who were able to be discharged from the hospital, and we looked to see how they did afterwards, we did find that there was worse outcomes in terms of this same patient population. You see, with multiple factors there, and the SAPS-2 is basically, which makes very much sense. If you were in a worse condition when you went into the hospital, then obviously you ended up doing worse as an outpatient in 3 months category. But vitamin D was also noted to be related to how patients did on the Glasgow outcome score at 3 months after their discharge from the hospital. And again, this held through multiple studies, but what we found was, it's associated with worse outcomes in the neurointensive care unit. We weren't exactly sure why this was, and because this was just an association, it's one of many factors that are related to how patients do when they come into the hospital, how they do, how well they recover afterwards. This type of these types of studies are very important to lay the groundwork and foundation for how we look at diseases, but to determine whether or not there's any clinical or benefit to this type of information, you need to do a randomized study, or you need to have some type of formal prospective study where you're controlling between patients who were receiving vitamin D supplementation or while they were in the hospital, for those who were deficient versus those who were not. So we organized a single center randomized placebo-controlled trial to investigate this. And again, we looked at the same population in the intensive care unit and came up with a study called the Randomized Clinical Trial of Hypovitaminosis D, or RECTIFY. And anyone who's involved in research studies know that the most important part of a study is coming up with a cool acronym. So as you can see, it does take multiple letters and some creativity to come up with something like that, but that is what we called it. And this was registered on clinicaltrials.gov. And as in all cases like this, it really was a very large undertaking. These studies just basically show what the demographic, and we had two groups, the group of patients, and they were all deficient in vitamin D, those who received the supplementation and those who received the placebo. So the groups were pretty well matched. And what we wanted to have as our primary outcome was the length of stay. Could we make a difference in how long people stayed in the hospital by 2 days? And we went through the study, and you can see that what we were successful, those patients who did receive vitamin D supplementation, and this was a loading dose at the time of their enrollment in the study, we were able to correct their vitamin D deficiency levels. However, we did not find that it had an effect on our length of stay as we had intended, or as we had hoped to determine. And again, in the table, you see that yes, we were very successful in correcting vitamin D deficiency, but it did not seem to make a difference in terms of the length of stay. So even though this was a negative study that suggested there was no benefit in the hospital, there is still a lot of investigation that's going on into vitamin D. And it is, again, a chemical or a steroid that has a lot of influences in the human body. And this study was not designed to look specifically at one study. It was whether or not a treatment for correction, which again is readily available and very inexpensive, could make a difference in outcomes. Now, vitamin D has become an area of interest in the cavernous malformation population. This is a study by Gibson et al. Out of University of Utah, out of the Whitehead and Lee labs, where they were looking at, are there drugs, are there medications that we can use to treat cavernous malformations? As we know, currently the gold standard for treatment is surgical resection. And there's not a lot in terms of either radiation treatments or medications that really have been shown to be a benefit. There are a lot of great studies that are currently in the process of being developed or currently enrolling patients and looking at whether or not drugs can have a positive effect on this disease. And this was a very novel strategy where they were looking at drugs that were already FDA approved, that were in use for other reasons, and trying to determine whether or not this could be beneficial for a different disease than it was initially intended. There are lots of examples of these types of medications. One example is that pretty much everyone's familiar with, Viagra. That was intended as a blood pressure medication, and one of the side effects turned out to be the #1 reason why it's prescribed now. Same with minoxidil. It was also a blood pressure medication, and found to have side effects that led to its repurposing for a different disease process. So that was the basis of this this experiment. Instead of coming up with a novel compound and trying to get the studies through with that, and that takes years and years and decades and millions of dollars to take a new compound and make that into a medication. These researchers thought, well, wait a minute. We have all of these drugs out there, all of these medications that are FDA approved. They have for a different indication. Let's see if any of these have an effect on cavernous malformations. And it really is a great way to look at our complement, our current complement of medications, and see if there's an added benefit that could be useful in a different disease process. And it really allows the scientists and the clinicians to get drugs to market or to get new medical treatments out there faster than what would be through the traditional routes. So what they found when they went through their studies is that cholecalciferol, or vitamin D3, even at physiologic doses, is very important in signaling pathways, basically on how the blood vessels are reacting and whether or not they're stable, and whether or not these, they use these in a rodent model, in a mouse model of CCM2, one of the one of the familial forms of cavernous malformations. And they found that there was actually a significant reduction in the number of cavernous malformations that they found in these mice with vitamin D administration. And that's pretty exciting news. And again, just as we had discussed previously, that's vitamin D is readily accessible. It's free if you go outside in the sunlight, but even if you take a medication, it's incredibly inexpensive. So in their study, they studied 2,100 drugs and compounds, and of those, only 2 were found to have an effect in their animal models. And they were able to decrease the burden of cavernous malformation in these CCM2 mice by 50%. So this is a pretty interesting and a very exciting finding. That being said, it didn't eliminate the presence of CCMs, and likely because the development of cavernous malformations is multifactorial, and vitamin D seems to play one role, one part of that cascade that leads to the development of these of the CCMs. And again, this is pretty exciting, and obviously it's a launching point for further studies. Dr. Awad's group actually looked at vitamin D levels as well as VLDL and LDL, or what's termed non-HDL cholesterol levels. And they wanted to see if this had any impact on disease progression. How did patients do, whether or not they had progressive disease chronically or progressive disease acutely, and what were their vitamin D levels, what were their cholesterol levels. And again, this was a study that they did prospectively, and they enrolled 43 patients and just again, just a simple serum test, a blood test, and identified the variables of vitamin D levels, as well as HDL and LDL and VLDL, or cholesterol levels. And they took extensive histories in these patients to see what features of their cavernous malformations throughout their history were relevant, and they came up with definitions of patients who had chronic aggressive disease, or over time this the cavernous malformation might have bled, or new ones that would have grown. They developed new ones, or the ones they had grew. And what they found was that patients who had chronic aggressive disease, which means that they developed these symptoms early in their life, or they had multiple bleeds, or there was a lot of cavernous malformations, they had significant lower vitamin D levels, and as well as non-HDL cholesterol levels. And this was in comparison to the patients who did not have chronically aggressive diseases, but who had relatively stable disease burden. So this is a little bit different, in the sense that this study was done in humans, and they were looking at this in a retrospective fashion as well as in the prospective fashion. And as you can see, with the patients who did have chronic disease aggressiveness, those patients tended to have lower vitamin D levels. On the table in table A, the black bar represents those patients who had chronic disease aggressiveness, and you can see their vitamin D levels were statistically significantly lower than those who did not. In the acute disease aggressiveness cohort, there was not a statistically significant difference. And then this kind of talks about potentially, is vitamin D, how does it affect in cavernous malformations? And it really is something that we're still trying to elucidate as to what specific mechanism and what part of the mechanisms for the development of them, as well as their behavior once you have them. And again, there's a lot, this paper out of Mayo Clinic, Dr. Lanzino, was looking at cavernous malformations which presented with seizures but not hemorrhages, and looking at what potential factors are related to their development of seizures in cavernous malformation patients. And they said what they found was patients with presenting with seizure without hemorrhage were less likely to have chronic inflammatory disease or use daily aspirin, statin, or vitamin D supplementation. So basically, these were the patients who were not taking vitamin D supplementation. They did not have the vitamin D levels in all these patients per se, but it does kind of point to another association where vitamin D may be playing a role. So in conclusion, what we know, vitamin D, it is a key role in many processes in the human body, including inflammation, as well as vascular endothelial stability. And there is an emerging body of evidence that vitamin D has an association with cavernous malformations. Like I said, all these are associations right now. There's still a lot of research that needs to be done in terms of what its direct role is and what part of the multiple factors that are present that lead to the development of cavernous malformations, where vitamin D plays into that, where it plugs into it. But there is a lot of enthusiasm just because this medication, as you said, is something that's widely available and can be free. Um, uh, and there are very few treatments out there that have that same cost benefit ratio. Um, so what we know when we were growing up, Flintstones multivitamins, we all read and we are all told that this helps you grow, helps develop strong bones, but maybe there'll come a time where not only supports bone health, but it might support calf mal health. And thank you very much for your time, and I'm happy to entertain questions.
Okay, fantastic. Thank you, Dr. Park. And I'm sure that we have received quite a number of questions while you've been talking. So right now, I believe we're up to about 12. So I'll just launch into those and let you respond. First question we actually received earlier today says, post-surgery, my mom's condition was fine, but slowly deteriorated over time, and neurologists have attributed it to nerve damage from the surgery. Nothing visible on MRI. Is there anything that can be done post-op to address this or manage it? A bit of background, my mom had a Pons angioma and it was surgically removed 5 years ago.
Well, that's there's a lot of reasons for how patients recover after surgery. That area in the brain stem itself, that's something that we term as high price real estate. There's a lot of very delicate functions that are within micrometers of each other, and doing surgery in that area is not come without some type of risk. And it is something that, again, when I elect to do surgery, and when there's been multiple hemorrhages, when it's accessible, and basically the standard indications for it. As to why the patient or why your mother would have a type of decline after her discharge from the hospital, there can be a lot of reasons specifically. The number one thing is make sure that there's no other processes going on. And again, the recovery from that type of surgery is not easy, and a lot of factors play into that in terms of how you do, how active you are, how active you're able to be, nutrition status, and it is, a scale of 1 to 10. Surgery in that area is a 10 in neurosurgery. So again, I wouldn't have a specific reason why that would happen, but definitely something you would work with your surgeon and your primary care physicians. The number one thing is to rule out other causes, other reasons for it. Make sure that the rest of her health is well, because that's going to be what's going to maximize her recovery and allow her to get back to the life that she had, or as close as possible.
Okay, thank you. The next question again came in a little earlier today. It says, my son was diagnosed with his angioma back in 2015 when he had a bleed. His angioma is non-operable. I just had his blood work done to test his vitamin D level, and it is low. The test for the vitamin D level this person had done on August 27th, so very recently. He was hospitalized back on July 17th of this year, 2019, for pericarditis for the second time. We believe the cause was mononucleosis. He also has vitiligo. The Vitiligo Foundation website also stated to have vitamin D levels checked. Is there a prescription or better vitamin D Dr. Park would recommend, and how often should his levels be checked?
Well, the research that I presented, it doesn't directly prove that vitamin D has an effect on CCMs in the human population. And there's not a prescription, there's not a dosage that we give for these patients. Obviously, if you're low in vitamin D levels, then supplementation just in general is something to definitely consider, and something that I would recommend that you pursue with your physicians, either your neurosurgeon or your primary care physicians for that. There isn't a specific dosage. Most of the prescriptions or most of the supplementation is just found over the counter. Is what you get at the pharmacy, at your local pharmacy store. In our study, when we were supplementing vitamin D in the intensive care unit, we were using what we call supranormal doses of that, because that was a one-time liquid formulation, and that is something that is really not available. But that was because we were trying to correct the vitamin D level very quickly in terms of making sure that our patients in the intensive care unit were able to normalize rapidly. That being said, if you needed vitamin D supplementation, I think it's one of those things where it is just a matter of taking the directions on the bottle. One multivitamin a day. Over time, that should correct again. And also, if they're able to, again, I'm not sure with vitiligo exactly what the restrictions are in terms of sun exposure, but definitely something to discuss with your primary care physician. And like we said, what we do know is the safety profile for vitamin D is pretty incredible. If we're looking at it as a therapeutic medication, as one of the best safety profiles that can be found. So it does seem to be, and hopefully as more research comes out and we can determine exactly what its role is, we'll have a much better idea of, if we need supplementation, how much do you supplement, what levels are considered appropriate. But in this instance, with the body of evidence that we have currently, it really is something that, if you do happen to be low, or someone that happens to be low, or in this case your family member, then I think normalizing that is a very reasonable pursuit. And in this case, it sounds like might be more than one condition. So.
Great, thank you. So just to follow up on that, it sounds like what you're saying is you can't be absolutely conclusive that vitamin D has the benefit for human populations, but there's a lot that would lead to us to believe that there could be that. But is there a danger in taking too much vitamin D to the human body, or?
Is there a danger in hypervitaminosis D? It takes a lot to get to that level, and more so that it's kind of it's a rare condition. Your body is very good at regulating itself. So, people who spend all day out in the sun, and they don't come with low or with super high vitamin D levels. So your body actually does a very good job in terms of regulating it. And it's more so, I think, that the people are not having enough, either for dietary reasons or environmental reasons. Again, I know me personally, I spend a lot of time indoors during the working day. So, my exposure to the sun might be nights and weekends, or weekends, and in the winter might just be, on a Saturday or Sunday. So it is something that it's something that can be addressed. I would never recommend taking more than is prescribed, especially for the supplements. And we don't know of any benefit as far as taking too much, to it. And again, this is an area of research, and I think it's very interesting personally, and I think as well for the community. But we don't have that level of data to say that it's that we can say and point to this as a guaranteed treatment. But on the flip side, it's also something that is very easy to do, and is certainly easy to address that, just individually.
Great. Thank you. Okay, next question. Based on your experience, do you think that IVF and or pregnancy increase your risk of a hemorrhage in an asymptomatic cavernoma?
You know, I get this question a lot, not just for cavernous malformations, but also for other neurovascular disorders like aneurysms or arteriovenous malformations. And what I always tell my patients that you know, you have to kind of live your life. We don't know of any increased risk per se with any of these vascular lesions and pregnancy. And usually the question is childbirth. You know, what we get presented from the obstetricians is it safe to labor? Is it safe to deliver, you know, traditionally, vaginally, or do these patients need a cesarean section? I don't think being an asymptomatic, you know, carrier and who has the disease of cavernous malformation, I would say that if a patient had presented to my office, I would absolutely encourage them to continue with what they were going to do. And I think as a father of three, I think it's one of the most incredible and vexing, and you know, the entire, as any parent knows, and the entire gauntlet of emotions. And I think everyone should, if they want to, experience that themselves. So.
Well, great. So that's wonderful. Next question. I just found out my son's vitamin D level is low. He was recently released from the hospital with pericarditis for the second time. He is the first child his cardiologist has ever seen twice for this. Do you think there's a connection with low vitamin D levels? And he also has vitiligo. So this may be the same person who asked the other question, I think.
It sounds similar. You know, vitamin D we know has a lot of it affects pretty much every organ system in the body. So again, in bone formation and development, people know that very, very clearly. Obviously, a lot of other conditions we're still learning about it, and you know, as time goes on, as more research is being done, we'll see how it affects skin conditions like vitiligo or cardiac conditions like pericarditis, and as well, hopefully, with cavernous malformations.
Great. Okay. Next question. Can you tell us a bit about the CCM Clinical Center program at UVA? And also, can you tell us, just to confirm, which location you're based at?
So the CCM Clinical Center, we're very proud that a lot of people put in a tremendous amount of work to get the center up and running. We have our full complement of specialists. I see all the patients, you know, as far as the cavernous malformations for neurosurgical consultations. We have a team of neurologists, two in particular, Dr. Brad Worrall and Dr. Andrew Sutherland, who also evaluates our cavernous malformation patients. You know, obviously the first thing is determining what treatments are necessary, or if observation is the best approach, and that comes through detailed history, talking with you, talking with the patient in terms of you know, how they're presenting, and hopefully they're presenting through the clinic, you know, again, and they present through the emergency department as well when there's a symptomatic hemorrhage. But for the clinical center, if there is a family history or a strong family history, or any indications that it's familial in nature, we have a world-class medical geneticist who runs our genetics lab and helps us define which of the genetic types you might have. The clinical center, it's at the University of Virginia in Charlottesville, Virginia, at the teaching hospital for the University of Virginia, and it's a beautiful place with a lot of history, and we welcome you to come by and visit.
Fantastic. Thank you. Next question. A few years ago, I read that people low on vitamin D are 40% more likely to have a stroke. And then this person writes, I think, in parentheses, after surgery. I told this to neurosurgeon Dr. Michael Lawton when he was at UCSF, and he agreed. I think that's the question. So I guess the question is, how do you feel about that?
Again, I think vitamin D, what we do know is it has multiple roles. And through my own research looking at patients, we did see that there were, even though we weren't able to prove it in our intervention study, I think there might be other methodological reasons for that versus saying that vitamin D supplementation doesn't play a role. But it has so many effects in the human body. What I always like to tell patients, especially for elective surgery, the better condition you're in before the surgery, the better condition you'll be after the surgery. And we like to focus as a neurosurgeon and how are you doing? How's your arms and legs move? How are you speaking and the neurological function? But also there's a whole lot that goes into recovery from surgery and how strong your body is and how resistant to you from the effects of surgery. So it definitely seems to play a lot of roles that we're investigating and that we're learning about. And more will be told in the future.
Great. There's a lot of questions coming in, so we'll just keep going here. I'm not sure we'll get through all of them, but okay, next question. How long does it usually take to correct a vitamin D deficiency once you start taking supplements?
It depends on how severe the deficiency is. Again, with vitamin D, part of the issue with supplementation is that people don't absorb the medication at the same rate. So there's a lot of kind of personal factors which could relate to how quickly you get corrected. Obviously, just taking the multivitamin, though, should be sufficient over time. And it's not a process of years. It's very likely a process of weeks before people are at least start to see a correction in their vitamin D levels. The most efficient way for us to improve our vitamin D levels is sun exposure, though.
Great. Thank you. Next question. A few years ago, this is the same as, that one got doubled, so we don't need to do that one. So next question. How do you decide when to recommend surgery to remove a cavernous angioma?
So that, again, is, there's several factors. Cavernous malformations or cavernous angiomas that are symptomatic, generally from a recent hemorrhage, and also surgically accessible. So we are always looking to make sure, to the best of our ability, that whatever surgery we recommend is going to benefit the individual. As we heard from some of the questions before, some cavernous malformations are inoperable. And it really has to do with what location of the brain the cavernous malformation is, because even under the best of conditions, we will disrupt a little bit of the normal brain trying to remove this cavernous malformation. Certain areas of the brain are very tolerant to that type of manipulation. Other parts of the brain are incredibly intolerant to that. So our threshold to remove a cavernous malformation, which is in the right frontal pole, like right up here by your forehead, and something that we can get to readily that's causing problems, either seizures or bleeding, we would generally recommend surgery as our first treatment. Somewhere, I think a previous question had a cavernous malformation in the pons that was deemed inoperable. If it is within and fully enclosed by the brainstem, unfortunately, surgery might cause more problems, or very likely will cause more problems than the cavernous malformation does. So in those instances, we think, well, we know that the surgery is not going to beat the natural history. And in those instances, for brainstem cavernous malformation, it generally requires multiple hemorrhages or something like that until, and part of it also in the decision making is when it becomes accessible. Because as the hemorrhage, unfortunately, as people have a hemorrhage for the brainstem cav mals, it might create a corridor for us to do surgery. So it's a very nuanced question, and it really does take a lot of conversation with the individual as well as a careful study of the imaging to determine who would be an appropriate candidate for surgery.
Yeah, yeah. And as we were discussing before the webinar began, you know, for many of us in the community, the absence of a go-to treatment is always one of the hardest things to live with. And certainly surgery oftentimes sounds promising, but for many of us, we've, you know, come to find out that it should be, it comes with a lot of complications, and should definitely be considered very, very carefully, I think, before taking that on. Yeah.
Absolutely.
Thank you. Okay, next question. What foods can help strengthen vascular walls, epithelial cells? Dark chocolate has been mentioned, for example.
You know, that's a great question, because you know we are learning more and more that how we live our lives matters to our health. We knew that before with all the bad things in life, like cigarette smoking, or you know, excessive use of you know, alcohol, or things like that, high cholesterol levels. But you know, more and more we're learning that the good things are important too, and or at least we're focusing more and more on the good things. And you know, I always recommend to my patients that that a balanced diet, you know, lots of fruits and vegetables, and you know what the FDA recommends in terms of the food pyramid. They're, you know, I think that's the updated ones are a fairly good indication of a healthy diet, and it's important, you know. And I try and keep my kids from eating too much processed foods, sometimes unsuccessfully, and I try and stay away from processed foods, and sometimes unsuccessfully. But you know, generally speaking, you know, if you're eating what's considered a healthy diet, that should provide all of the vitamins and nutrients, and the building blocks for health that your body needs. So as far as specific treatments, or lots of foods that are rich in vitamin D, and you know, that if you did have low levels, that might be a great and easy way to work to correct that.
Great. Next question. One of the side effects of Tegretol, seizure medication, is light sensitivity for your eyes. And then the person writes in parentheses, I'm assuming from the UV rays, question mark. Just wondering about this. When we need vitamin D from the sun, but these side effects cause me to want to avoid the sun.
That you know, that's a good question. I'm not sure where the light sensitivity comes from with Tegretol, but the vitamin D is absorbed, is processed through exposure to the skin. So if light sensitivity becomes an issue, it might be a good pair of sunglasses or some type of sunshade to mitigate that. If it is significant enough that you can't go out in the sun, then the multivitamins are also a great option.
Okay, great. The next two questions I'm going to ask together because they're short, and they're really about the, again, vitamin D supplements. The first person writes, additionally, I work third shift, so I don't see the sun very often. What would be the best supplement to take? And then the next question is, what is considered the ideal vitamin D level or range?
So whatever the best vitamin D supplement, it's all the formulations are, you know, there's not a specific brand. It is considered a generic for all intents and purposes. So any of the supplements should be suitable, taking as prescribed or as indicated on the bottle. Even a multivitamin, they almost always have vitamin D in them as part of the complement of vitamins and minerals that they provide. And as far as vitamin D levels, usually they are measured in nanograms per deciliter. And right now, as far as the normal range, I believe it is around 25 to 30 nanograms per deciliter. But I would have to look that up. I apologize, I don't have that offhand.
Great, thank you. We also have a couple of questions that are coming in through the chat window, so I'll try to bring those in because I hadn't seen them until now. The first says, please elaborate on the non-HDL cholesterol level that is normal and what is negative for endothelial health.
So non-HDL cholesterol, that is now, previously they used to measure low density and very low density lipoprotein. That's what the LDL and VLDL stand for. And they're kind of getting grouped because the HDL is a high density lipoprotein. That's always, and what we're looking at what was looked at in these other studies is non-HDL cholesterol level. As far as what it is that's negative for endothelial health, again, because we don't have the information to say that this is directly related versus a finding that we see in certain patients, there isn't a dedicated level that should be targeted as far as that's concerned. And I apologize, but as more information comes out in the future, we may get those discrete values. But as it stands, with our current knowledge, that's not something that we have that information for.
Okay. Then the next question is actually from a different person. Says, is non-HDL cholesterol the same as LDL cholesterol?
And so that was a common, non-HDL is LDL and VLDL as a combination.
Okay, so it is not the same as
LDL is a part of the calculation for non-HDL, but there used to be two separate types of cholesterol, but they're just grouping them into one.
Okay, great. Now back to the Q&A questions. I have a cavernoma in my right parietal lobe, and I was told first that it would have be best to have it removed, and then was told by another doctor that it would be best to just watch it. I have had one bleed, no seizures, and only have mild symptoms. Does vitamin D help does vitamin D keep the cavernoma from bleeding, ? And do you recommend removing a cav where there are only mild symptoms? And I think we kind of talked about that. Do you recommend taking vitamin K12 along with D3? I have read that they are synergistic. Is vitamin K2 safe for vein that has bled?
So the vitamins in general are all safe for any patient regardless of unless you have some very unusual medical conditions, but there isn't a prohibition to taking certain vitamins, vitamin D or vitamin K for in a cavernoma population, cavernous angioma population. As far as, again, the recommendation to take vitamin D, we don't have enough information to say that it's going to be of benefit, but we are finding that it does appear to have a role. And again, until more studies, as Dr. Lee and Dr. Whitehead's lab has shown, when that translates from a mouse model into studies in the human population, then we'll be able to gather that evidence and determine, if vitamin D supplementation is going to may have the same effect in humans as it does in a mouse. And if so, then the work is in what levels are appropriate, how much to supplement. So there's still more information that needs to be had before we can recommend that and say that it's going to have a positive impact. But
Okay.
again, it is very, very, very interesting research. As far as resecting the cavernous, the cav mal, it really does depend on where it is in the brain, and everything with surgery is a risk-benefit ratio. As what is the risk to causing an issue as a result of surgery versus what is the benefit? So the parietal lobe has a lot of, is a pretty big area geographically in the brain, and there are some areas that are more delicate than others. And the determination to operate really depends on the exact location of where the cavernous malformation is.
Great, thank you. Is there any relationship between positive vitamin D levels and the University of Penn study regarding gram-negative bacteria, leaky gut, and the role emulsifiers play? In other words, does vitamin D play a positive role in the gut microbiome?
That is one area that I'm not personally familiar with, but you know, what we know is that it has so many varied effects on every organ system that it very well could have a significant impact on the gut biome. And we are learning more and more about the interconnectedness of things too. There's actually a lot of research that shows how our gut is doing affects how our brain works, how our brain functions, not specifically with cavernous malformations, but in other areas. So I think that is just a key example of what the effect of this is, and how multifaceted and the areas of research are in vitamin D.
Thank you. Still a few more. We'll keep going and then we'll check in and see. This is a fun one. It says, Dr. Park, just curious if you take vitamin D daily, and if so, what type and what dose?
I take a multivitamin every day. Like I said, you know, my sun exposure is woefully short. I wish it were more, but work responsibilities oftentimes get in the way of that. I take, you know, I'm going to be, as I had mentioned before, I'm the father of 3 young kids who take multivitamins. I just steal theirs. So they take gummy form, and I take that too. It's too complicated having multiple bottles of vitamins around, so we simplified the process. I take my kids multivitamin. I have checked the bottles though; they're remarkably similar between the adult and the children's formulations of multivitamins. So I just take a generic multivitamin.
Great, great, and they taste better too.
They taste absolutely better.
Question. This is from one of our members, Pam, who is her daughter. Pam's vitamin D is 70 with 10,000. Is that too high?
You know, I would have to check and see. As I said before, I'm not entirely sure what the normal levels were, but it's definitely something that you should check into with a pediatrician or primary care physician. There isn't any benefit that we know of to having excessively high levels, and basically what we're trying to maintain is just normal levels and not low levels. So that's something definitely to check with your daughter's physician.
Okay.
I think we have time for one more question.
Okay, great. Boy, there's 1, 2, 3, 4, about 5 to choose from. I'm going to just pick the one that jumps out at me. Have you seen any relationship between bleeds and the heat? I've heard that heat thins our blood, which makes natural vitamin D. And then this person says in Texas, it's a little difficult. So,
as far as cavernous malformation, bleeds, and whether or not that has any relationship with the environment and the temperature, there's nothing that I'm aware of in terms of what's been reported in the medical literature. The heat can play lots of roles on the body, and obviously you don't want to get dehydrated or have a heat stroke or anything like that. As in all things in life, moderation is the key. So what we do is, if you're able to, it's not something that we recommend sunbathing, because excessive excessive amounts of sunlight can lead to other problems, as we know of, like skin cancer. So it's not something that we would say you need to go out and do X number of minutes per day, but it is something that if you do find that you're low in vitamin D, as we had mentioned before, a vitamin supplement is an excellent alternative if you do not have the ability or the time to really take advantage of the sun.
Great.
Excellent. Hey, so thank you so much, Dr. Park. That was very interesting. We got lots of great information. Sorry we didn't get to everybody's questions. We did the best we could. Thank you so much, Greg, for moderating the questions. And we're going to sign off now.
And before we do, do we know if the recorded version of the webinar is available?
It will be available. Yes, it'll go up on the YouTube channel.
Okay, so everybody can check there, and there'll be a link or something if they want to.
Yep, we'll post the link on the Facebook page and when it's ready.
Fantastic.
All right. Thanks, guys.
Thank you, Dr. Park. Thanks
Thank you very much.
Okay.
Absolute honor. Thank you.
Okay, thank you. Good night.
Good night.
Night.